Hi everyone, this is Shalu Kumar again from OSCE Nurse Training Cambridge. I'm an experienced OSCE nurse trainer for the NMC OSCE exam in UK, and I'm NMC registered nurse with lots of clinical and educational experience, and I'm also the lead trainer for OSCE Nurse Training Cambridge. Welcome back to my YouTube channel again. If you like my videos, please press the like button now and subscribe. Okay, and share it with your other friends and colleagues who may be preparing for OSCE. Okay, so we are going to go into today's video. Like I said, last few weeks I've been doing overview series for your API, clinical skill, then professional values last week. So we're going to go through, look through the evidence-based topics today. Evidence-based practice, which is one of your written skill in your OSCE exam. It's mandatory skill. You have 12 topics and you will be given one topic to do. So we're going to look at overview of all the topics, what they are. I'm going to tell you what is the theme in that topic, and just to give you some tips how to remember that topic easily. Okay, so we will go through all 12 topics. We won't go in too much detail, but we will go through look overview that would really help you to understand these topics and then answer your questions. Okay, so evidence-based practice. So what is evidence-based practice station? So this is a station where it's a written station, is 10 minutes. Like I already said, there are 12 topics in your syllabus. So you will be given a scenario to read, then you will be given a research study article to read, okay, a small article. You will then write your recommendations or conclusions in bullet points, okay. So that's what you need to do in 10 minutes. So the evidence-based practice station is to check your knowledge of current nursing practices which are based on current evidence and research, okay, because the nursing keep evolving as like any other profession. So as the research goes and the evidence goes, we have to change our clinical practice as well. Okay, so you have set 12 topics and you need to know what is the current clinical practice in those topics, what is the current clinical evidence. Okay, so that's what we're going to look at today. So moving on to the next screen. So let's look at topic by topic. The first one is ankle sprain. So ankle sprain, this is just the basic idea is you will have a scenario where a patient is coming with soft tissue injury like ankle sprain, and the patient is told by the doctor that there is no fracture. Patient can go home and just take some ibuprofen for pain, but the patient is asthmatic. Okay, so the patient is asking you as a nurse, can they not take paracetamol, because normally they don't take ibuprofen. So they're just asking you, would it be good pain relief still? The paracetamol will be okay to take for ankle sprain, pain for ankle sprain. So okay, what does the evidence shows clinically? Means evidence is actually quite clear that paracetamol and ibuprofen, which is a non-steroidal anti-inflammatory, they both work in the same way for pain relief as long as it's only soft tissue injury. Okay, soft tissue injury means the bone is not involved, there is no fracture. So for the soft tissue injury, there is a good evidence actually that both work equally good for pain relief, and we already know ibuprofen is contraindicated in patients who got cardiac, renal or like bronchospasm. Of course, your patient is asthmatic, so you would recommend that it's better choice for them the paracetamol. You will tell the patient sometime the clinician think anti-inflammatories like ibuprofen is better pain relief, but there is no evidence to suggest that. Okay, so that's that one. Then we are going to go to bedside handover. So bedside handover is all about just like, say for example, the scenario may be that a student has seen some of the nurses on the ward doing bedside handover, and the student is then asking you, is bedside handover a good idea to hand over patients on the bedside rather than in a room? Okay, because you know certain clinical places we do handover on the bedside, certain places on the wards we just go in a room and take handover. So is bedside handover a good idea? Yes, the research shows that it is a good idea because the patient feel part of their care, they feel involvement when you do the handover on the bedside. But there are just some differences. Patient would like a family member or a carer or a friend to be present. Nurses don't think that's important at the bedside handover. Again, patients don't mind if you hand over sensitive information quietly over the bedside, but the nurses have a huge preference for sensitive information to be given away from the bedside. So we really do need to actually look into design of it, we need to improve the design and the process of bedside handover. Then we can use a even better effective tool, nursing tool in clinical care. Okay, so that's that one. Cervical screening is easy one again. So you could be a practice nurse. Scenario could be the lady wants to have the smear test done, but she's a bit apprehensive. Okay, she's a bit hesitating, so she doesn't know the whole evidence behind it, why is it important, and then you're giving her information or a health education, why is it so important to have cervical screening regularly for women, so to prevent obviously cervical cancer. There is slight change, and if you watch my other video, there is a change in cervical screening guidance in nationally now. So it used to be every 3 years, but now it's every 5 years. Okay, so you do need to look into that. So all the videos, all the different topics are covered on my YouTube channel already, so I will add the link, the playlist link, to the description of this video below. So that's that one. So it's an easy one. Just go and see what should be given. What would you say to a patient who's got who's a bit hesitant about having cervical screening? Okay, so we're going to go into next one, looking at dementia and music topic. So what does the research say? So your scenario could be like a lady or a person has brought their parent or grandparent into say outpatient clinic, dementia clinic, and they're asking you that they heard that music can be beneficial for dementia patient. Can their relative also have music therapy? Would it be recommended for them? So what does the evidence? Of course they're going to give you evidence-based study in every topic, but what is the general idea here? So for dementia, yes, there has been some obviously there has been research where they have done trials and they have done surveys, and it does show, one of the studies does show, where patients had at least 5 sessions of music therapy, that it can be beneficial. Okay, but it helps with different symptoms of dementia. So music therapy can help with the symptom of depression for dementia. It may not help with agitation, but there is obviously, because it does help with depression, so again there is a good reason and logic that patient then should be given music therapy, because it may improve their quality of life. So evidence at the moment is only that it does help with depression, but that is a good enough reason for a patient to try that. But the only thing you do need to give advice that we don't know how long the good effects of the music therapy last. Okay, it may last a day or month, longer, we don't know. Okay, so at the moment we don't have that research to back it up how long the effects will last, but yes, there is a positive effect of music therapy on dementia. So that's that one. Next one, we're going to look at diabetes. So that's a easy one. That is just that a patient may come and ask you, they could be newly diagnosed type 2 diabetic on metformin. So they may ask you what are the signs and symptoms of hypoglycemic attack. Could they have a hypoglycemia with metformin, and what would they do if they have some symptoms, and what are the symptoms? So it's just, they just watch the video. It's very clear what advice you should give to a patient around hypoglycemia. Okay, so it's about that. And moving on to next one, female myocardial infarction. So there is symptoms of heart attack in female. So what is all that about? So what does the research say? So scenario could be that you got a patient who has a history of heart disease, hypertension, maybe kidney disease or something similar, who are a slightly higher risk of having MI, which is myocardial infarction. So this patient is asking you, this lady is asking you, what should she watch out for? What are the symptoms of a impeding heart attack? So what would it look like, and what should she do about it? Now, having said that, so what does the research say? So research is the evidence shows, the studies show so far, that all females do not have chest pain as prominent sign of heart attack. So that's why there is a disparity between males having heart attack and surviving from it than female. So why is that? Because the chest pain is not the most obvious sign when a woman has a heart attack. They may have chest pain, they may not have, or they may have very mild chest pain and they may not recognize that they are having heart problem or they are having a heart attack. They may have other symptoms like cheek pain, shoulder pain, back pain, bit of feeling unwell, teeth pain or jaw pain or the shoulder pain, but they may not have very severe chest pain, which is a prominent sign in male but not in women. Women may not experience chest pain as the main symptom of heart attack, but they may still be having myocardial infarction. So you should then tell the patient to watch out for these symptoms. If the lady is unsure, go and get it checked out in A&E to just rule out any cardiac cause for all those other symptoms. Okay, so it's really important, because the presentation of myocardial infarction can be different in female than male. So that's what you need to concentrate on, that one. So next one, we're going to look at fever in children. So fever in children, so you may have a scenario where a parent, like say for example, parent has brought their child in for vaccination or something, and you are the practitioner or the nurse giving that vaccination, and they may ask you that if a child develops fever due to vaccination or due to any other reason, should they give ibuprofen, should they give paracetamol to the child? So what does the research say? Well, the evidence is saying that both are fine as antipyretic for children. Children can be given paracetamol or ibuprofen, both, and they're both effective therapies for bringing the fever down in children. But the only thing is only thing is, if the child is having ibuprofen, it's recommended that they have something to eat first, even though it can be given, some of the evidence says that it can be given without any major side effects for 7 days without having food. But the good advice is always that the child should be encouraged to eat something before taking ibuprofen. That's the only difference between paracetamol and ibuprofen. They cause similar kind of side effects in children, and only other thing is, if the child is you should give a child something for fever if they're really distressed by the fever, because fever can be a quite automatic response in children to any allergens or any bacteria and viruses, because as child you come across lots of different things which your body hasn't seen before. So the fever can be just a reaction of that, and it may not be that high, it may not be that distressing. If it's not that distressing, then you don't need to give anything in that case. So that's that one. So moving on to pressure ulcer prevention. So there is this is all about, so if a patient is asking you can they foam dressing, so can the foam dressing be used for them to prevent pressure ulcer on their heel or sacrum, because they are high risk of developing pressure ulcer. So what would be your advice as a nurse? What does the studies show? So there was obviously a couple of studies done. One shows that yes, it can actually help with prevention. The foam dressing can help prevent a occurrence of pressure ulcer development, but only by 10%. So there is still high chance the patient may still have pressure ulcer, especially when they stop using the dressing. Other thing, it can cause a little bit of skin irritation as well. And you do need to say, because it's like the patient in this scenario is normally a male patient, so you may say as being a male, the patient is at higher risk of developing pressure ulcer than female. So the good advice will be, yes, you will refer the patient to tissue viability nurse for to discuss if the foam dressing is a good idea for them, if it's a good intervention for them. So you will make that referral, but you will also tell the patient there are a lot of other ways to prevent pressure ulcer, like we all know, good nutrition, changing position, increasing activity if your patient can, and changing the position regularly, and and just assessing the pressure areas for any early signs. So those things can, good hydration, those things are a really good interventions to prevent a pressure ulcer. So that's that one. And moving on to next one, restraint. So there could be a scenario where one of the staff or one of your colleagues is you are having a kind of a professional discussion if restraining is a good practice in nursing. What does the research show? So research is obviously shows it's no, because restraining someone is going against their human rights. So of course it's not a good clinical practice. If you have a obviously a patient who may harm themselves or other staff or other patients, then it can be used as a last resort, or it should be used as a absolutely last resort, because care and compassionate care and discussion with your patient with care and compassion may actually avoid the need of using restraint at all. So in some cases, unfortunately, it may be used if the patient is at risk of harming themselves or staff or other patients. Okay, but it should be just as a last resort. Why? Because it promotes fear. It actually is quite emotionally quite distressful for the staff as well, and of course it breaks that good rapport between, good trust between nurses and patients. So of course it is not a absolutely not a good idea to restrain patients, but like I said, sometimes it cannot be avoided for certain reasons. Saline versus tap water. So this is about cleaning wounds. So your scenario could be around that you're in community and one of the patients has got a long-term ulcer on their leg or something, maybe because they're type 2 diabetic, or they are arterial insufficiency patient, or poor circulation, whatever the reason. So they got this. So they're asking you, because they've been cleaning this with normal saline daily, but it's costing them a lot of money to buy normal saline. Is it okay if they just clean it with tap water? So I've already done all these topics, like I said, on the video, so you just go and watch it in detail. But at the moment, I'm just gonna quickly tell you the evidence and overview. At the moment, the studies have been done, but they were very, very small studies, but they've been put together, so there is no conclusive evidence that whether normal saline is better or the tap water is better, or tap water is going to cause any harm to your patient, or they're going to feel less clean, or it's going to cause more infection. There is no evidence about that, and there is no evidence that it will delay wound healing or normal saline will promote wound healing. There is nothing like that. So there is no conclusive evidence at the moment. So at the moment, I guess if you have to really, if the patient is not happy to buy the normal saline, you can only just say, okay, the tap water can be cost-effective method. We don't know it's a safe method. We don't know it's the most effective method for wound healing, but it may be cost-effective method for cleaning the wound. But there is not a conclusive evidence on this. Okay, so next one is smoking cessation. So this is all about, like I said, all these videos, all these topics are covered. This is all about whether e-cigarettes are better in helping patients to stop smoking, or nicotine therapy. Which one? Well, they both can work. The research shows both can work. E-cigarettes might be a little bit better for the patient because they may get a little bit more, I guess, satisfaction from it, because they're still smoking the e-cigarette, I guess. But the research shows they can equally work. Both have different side effects, so you have to read the scenario, watch the video. So they have both different side effects, but they can both work and they can both help patient to stop smoking, as long as patient is still attending face-to-face sessions. Because without attending that face-to-face sessions to have the support, it may not work, and none of the methods may may not work. Okay, so any of the methods may not work. So that's really important, and you should encourage your patient to, alongside these methods, you should always encourage them to attend face-to-face smoking cessation sessions. Okay, so that one. And the last one is honey dressings and leg ulcer. So what does mean? It would be just a patient is asking you who got a leg ulcer whether you can apply honey dressings on their leg ulcer rather than just the normal dressing. So what does the evidence shows? So far the research shows there has been lot of research, and there has been lot of different honey dressings on the market for leg ulcers. So what does that? There have been 2 studies, one big one and one small one. The big study shows there hasn't been that much a conclusive evidence that honey dressings will help heal the leg ulcer quicker or decrease its size. It doesn't say at the moment, it doesn't show that it will decrease the time of healing or decrease the size of the ulcer in any ways, honey dressing. Then there was a smaller study which does show that if the patient has a MRSA in that leg ulcer, if he's infected with MRSA bacteria, then it may be beneficial. Honey dressing may be beneficial because it's got antimicrobial properties. But there are other points in this topic, so you have to just watch the video and learn them, but that's just the main ones. So at the moment you will say to the patient that the dressings will be done as per the trust policy with the normal dressing rather than honey dressing, because there is no enough evidence that it's a cost effective method, because honey dressings are quite expensive. So, and it doesn't show that they are effective at the moment in healing leg ulcer any quicker. So that's the reason that the dressing will be done as the normal protocol for the hospital or the trust. Okay, so that's that one. So I hope it just give you a good idea of what these topics are. Of course, you will be given a scenario which may look slightly different to what I have discussed with you, but I hope the discussion will help you to just learn the answer a bit better, bit easier way rather than rote learning, because you understand them better. So that's what our intention is in our training, always that you understand things, you understand the logic of things, because then it's easy to remember, because in exam everybody is stressed anyway, and if you just rote learn, you're gonna forget things. Okay, there is a very good chance you may forget things if you come off the script. So script doesn't help in a long way. Okay, knowing the logic and understanding is really important, and that's what we make sure we do in our training if you come and do training with us. So I hope you like the topic and the video. If you do, please press the like button now and subscribe. You can email us on OSCE@outlook.com. You can visit us on OSCE.training.com. You can go and check our Google reviews. I will soon be back with another video for you. So bye for now.